Dr. Stan Wu is the director of the School of Optometry and Vision Science here at the University of Waterloo. He held the position of Chief of the Vision Rehabilitation Service, founding director of the UEI Center for Sight Enhancement, and director of the Residency in Low Vision Rehabilitation. Dr. Wu has also practiced part-time in the Texas Medical Center with the Retina Consultants of Houston for 18 years. And he's going to talk to us today about AI for ocular health. So please go ahead.
Thanks very much, Peter. Can you hear me?
Yes.
Excellent. Very good. And my slides up there?
Yes, they're there.
Excellent. Very good. Thank you. Yeah, a bit of an old bio. So I actually grew up in Waterloo, but I was down in the States for over 20 years, and I'm pleased to be the director of the School of Optometry and Vision Science. Just returned a little over 3.5 years ago, and very excited to talk to you today about AI and ocular health. First off, the caveat being that I am not an AI expert, but certainly a big AI fan. And again, thanks for the organizers for the opportunity to talk today. Just to set the stage, that vision is oftentimes actually taken for granted as far as one of the areas of health, as far as public health imperatives. And the World Health Organization for the very first time had presented a vision report in 2019, highlighting the lead sort of concern was that over 2.2 billion people in the world have some level of vision impairment. So 2.2 billion people, of which almost half could be addressed either preventatively or actually sort of remedied. As we look at an aging population, the other statistic that is quite compelling is that everybody, if they live long enough, will have some sort of impact on their vision in some way, shape, or form. And with increasing age, the level of chronic eye diseases such as age-related macular degeneration and glaucoma are continuing to increase. So if we look at our slide up in the upper right-hand corner over here, we see that age-related macular degeneration is an eye disease that affects our central detail vision. So if you look at the picture on the side there of the two boys, if you're trying to look at their faces, they'd be obscured. Between 2020 to 2030, it's anticipated that people suffering from macular degeneration will increase from 196 million to 243 million worldwide. And it is one of the most common causes of vision loss in North America. Similarly, glaucoma is another chronic eye disease, somewhat like hypertension in the sense that you don't really know that you're missing vision until it has progressed fairly markedly. And you'll see in the picture below, it robs us of that peripheral vision. So you may have some sparing of the central vision, but over time, we lose that side vision. So both of these diseases are clearly very impactful, projected increase from 76 to 95 million people by 2030, and ultimately has, again, enormous human impact and toll. And we think that perhaps maybe this is just a developing world problem. The World Health Organization clearly has a global mandate, but within Canada itself, we recognize that over 1.5 million Canadians have identified vision loss. 5.9 million more have an eye condition that could cause or lead to vision loss. And again, with an aging population expected to have sight loss double in 25 years. So this is clearly a very important problem of which technology and the ability to leverage things like AI can have an enormous impact. From a cost standpoint, if we look at the economic impact, again, employment is reduced when you have vision loss, and the projected annual vision loss is about $30.3 billion by 2032. So clearly this is an area in which there could be a lot of potential impact and benefit. But if we look now instead of at the economic aspects, we also think about the individual toll. So if patients who are diagnosed with vision loss oftentimes have elevated prevalence of isolation, depression, they're at greater risks of falls, as you can imagine if you're missing that side vision, and then certainly increased mortality. On the flip side, as we think about children and the importance of vision in successful learning and education, that also has a critical component in order to be able to attain success. So as we look at the World Health Organization report, there were three major challenges that were sort of identified. I've already mentioned sort of the first one, which is as demographics and lifestyle increase, the prevalence of these kinds of chronic eye diseases like macular degeneration and glaucoma will continue to increase. But where there is really potential, particularly for the University of Waterloo and faculty here, are that data are often lacking and health information systems are weak. And this is actually an area of strength at the University of Waterloo across the institution. Obviously, eye care can be fragmented. There are different systems. There are lots of different opportunities. And so again, to point out that although we have an excellent system, it still has room for opportunity for improvement. And that's the focus for the collaborations and the excitement that I have with working with colleagues in being able to address particularly the health information systems and the possibilities of what that could bring. So at the School of Optometry and Vision Science, we have multiple missions. We have clinical education and training of optometrists who are graduated to practice anywhere in North America to the highest level of their ability, leveraging simulation techniques to accelerate their development. We also have an active clinical program ranging from patients of all ages, ranging from wellness through diagnosis, management, treatment of disease, all the way through to rehabilitation when that vision loss is irreversible. And of course, fundamental research, discovery, being able to understand the mechanisms of age-related macular degeneration to prevent that progression, and even using the eye as a window to the brain for using imaging as a mechanism for the early detection of neurological diseases such as Parkinson's, Alzheimer's, and the like. So there are lots of different activities in which we're able to contribute and collaborate. But I think, in addressing this group here for sort of Industry Day, I guess, the university itself has a number of strategic commitments, and I'll draw your attention to the one at the bottom here, which is to lead at the interface of health, technology, and society. So across the university, whether it's in the engineering, math, computer science, the faculty of health, we have lots of areas of excellence in this space. And I think part of the reason I may have been chosen is because I am actually a super fan of a number of these different areas. Lots of different folks working in the space, but the ones that have come to mind in my recent sort of collaborations and outreach, Advanced Interface Design Lab, so that's Catherine Burns's lab in System Design Engineering, the Kimia Lab with Hamid Tazoush, looking at knowledge inference and medical image analysis, Plinio Morita's lab with Ubiquitous Health Technology, and certainly all of the different areas and resources that are available has been kind of one of the exciting things for my return to Waterloo after many years in the US. So lots of really smart folks. I'm going to just touch upon very sort of broadly three different sort of projects that we have underway. Certainly not the level of detail and sophistication of the previous presenters as far as the AI piece. I'm primarily a clinician, big C, scientist, small s. And so I think from my standpoint, it's to see the potential of what AI could generate. So this first one, AI for improved ocular health care. So the collaborators are Hamid Tazoush, Catherine Burns, Pino Morita, colleagues in the School of Optometry and Vision Science, Chris Hudson and Nadine Furtado. And really what we're looking at is to tackle those big problems identified by the World Health Organization. So how can we take all of the disparate elements of clinical information, diagnostic imaging data, and functional assessments to be able to combine all of those things so that we can be able to better predict not just the diagnosis, but to predict what treatments may be effective and what the pathway might be if, in fact, patients continue to be at risk. So right now, as many of you know, FDA has many approved things for the classification of different diseases. So diabetes is is one of the most well-developed. So being able to classify whether a patient, based on an image of the back of the eye or a fundus photo, we can tell whether they have diabetic retinopathy or not. Those things are fairly well developed, and I understand from Hamid that this is based on a supervised learning or classification that is based on sort of clinical experts. But an area that is really kind of still to be explored, if you will, is this notion of unsupervised learning. And again, I have a very sort of rudimentary understanding of this, but being able to look at cluster and search algorithms and small sample sets rather than having huge data sets necessarily allows for being able to identify information that could be informative to clinicians. And so we've kind of picked two different disease processes at different sort of prevalence levels, if you will. So glaucoma, very prevalent eye disease, one of the leading causes of vision loss in North America, and then choroidal melanoma, which is essentially an eye cancer. Relatively uncommon, thankfully, but certainly very important to be able to diagnose and treat accurately and in a timely fashion. So looking at both of those dimensions and generating sort of the data sets to help underpin them is sort of where we're exploring right now. So here on the right-hand side, you see a diagram of typical diagnostic information. So an OCT, optical coherence tomography. In this side here, you see the optic nerve. It takes a scan. It has it sort of rolled out in profile. So it allows us to see the different levels of thickness in the different layers, the nerve fiber layer being most important for glaucoma. And there is already sort of some clinical decision support. You see the green, yellow, and red highlighting whether it's at risk, something to monitor, or definitively a concern. And it's based on normative databases and the like. And this is sort of where we are as clinicians. So we have lots of different functional information, diagnostic information, clinical data that we gather, and we're able to assemble that together with clinical practice guidelines and to make determinations in diagnosis and treatment. And we know what we know because of the way we're trained and how we're able to practice. From a cognitive work analysis standpoint, it's interesting to look at it from the outside and look at the workflow and determine, are these decision points the most efficient possible? What is the data that's being integrated? How does it flow through? And can we design different interfaces in the way that we collect it and then reposition or redisplay it in a way that actually makes it more intuitive, more effective, and perhaps even more efficient? And that's the cognitive work analysis that Catherine Burns's group is assisting us with at this time. So the data itself is really sort of the key element to being able to bring this disparate information. We need to protect the patient's privacy. We need to be aware of those dangers and challenges. We need to be able to make sure there's anonymization, and that ultimately, as we aggregate all of the data, how to be able to coordinate, collate, and ultimately make it usable. And that's where Kunio Morita's lab has been has had a lot of experience and work in creating sort of these data lakes and be able to, again, aggregate disparate amounts of information. And then finally, with the imaging itself, whether it's OCT or visual fields or the like, being able to now take a look and see whether this unsupervised learning can help us to better understand how to characterize these different diseases, particularly glaucoma, with the goal of ultimately being able to see whether or not it can help to accelerate our ability to to coordinate care for our patients. So the image that Hamid had shared with us that I think was most compelling, and I didn't have a Star Trek slide up, but he sort of described an image in which you'd have a display screen that would allow us to have all of this diagnostic information in a way that is intuitive from a clinician standpoint, the way that we think and how we could assemble everything in a heuristic way. And then being able to maybe pull up different case examples. So for example, with the choroidal melanoma, being able to look at the characteristics, the age, the risk factors, and the other elements, and then be able to pull up ones that had similar sort of characteristics. And from there, being able to predict, is this likely to change into, is it in fact a malignant melanoma? Will it progress? What rate will it progress? So that we have a more intuitive way of being able to access that information and again, make those predictions. Particularly with glaucoma, the challenge is, of course, as everybody would expect when you're diagnosed with a sight-threatening disease, is will I go blind? And how can I stop my vision loss if, in fact, I have this diagnosis? And the idea now is that although we have these sort of normative databases to compare, that simply allows us to make, with some level of confidence, the diagnosis. But what would be really helpful is to be able to take all of this disparate sort of information and be able to look at it in a systematic fashion, to be able to determine if there are ways of creating more accurate predictive models so that we have better information in which to be able to guide our patients and then be able to more aggressively treat if it looks like they are at greater risk for whatever number of risk factors. So again, very interesting opportunities and certainly a very exciting element to be able to explore that recognizes sort of the big health data as being sort of a tremendous resource. So if we shift gears now and think about from a patient standpoint, not as a clinician looking at AI to help with clinical decision support, but rather from a patient standpoint, trying to improve their experience, their outcomes, and ultimately the savings that are realized by keeping people healthier for longer. It's interesting to see how we can work with digital platforms and creating environments to nudge the behaviors that would be ideal. So in this case, again, we look at glaucoma. So in Ontario, HQO has created glaucoma standards for adults that very well delineates diagnosis, management, treatment protocols, and opportunities for patients to be able to really get the optimal treatment. But there's still a gap in this. And I think the challenge is that you may be diagnosed with a sight-threatening disease, but at the end of the day, if you have to be putting in drops in your eyes and they sting, or they cause your eyes to be red, or they're just uncomfortable, or you forget, adherence to the treatment is oftentimes the limiting factor. And that's a gap, because if you're not in the chair with the practitioner at the time, it's difficult to reinforce that because they're spending months and months between visits. And so if they just discontinue, the disease can continue to progress. So can we leverage digital tools and technology and create virtual environments in which they're able to now have access to that information in a way that they would consume it more naturally, that it's sort of evidence-informed and curated, if you will, in an engaging and informative way, so that they really take ownership of that disease process and are able then to persevere when they have those adverse sort of reactions in the short term. So can we actually have patients define that circle of care so they their daughter or caregiver can be able to help be informed about what's tracking as far as their clinical data, being able to determine are they taking their medications on time, and to be able to intervene if it looks like they aren't really adhering to the treatment protocols. In addition, the notion of being able to have health coaches have touch points in between those regular visits, again, from a virtual standpoint with the appropriate training and contact, is that able to make an influence? And I think related to the previous talk about natural language processing is, can we get to a point where, from a medical language standpoint, you could actually have some of these frequently asked questions and interactions be able to be automated to increase the efficiency still further? So the platform itself has had success in different areas. Cardiovascular disease, as you can imagine, also has that challenge with adherence to treatment, mental health, and also, of course, diabetes, which, again, is epidemic, and really both a lifestyle and behavioral change and support necessary to make sure that patients have the ideal outcome. So an interesting, again, adaptation of the technology from the patient standpoint. And then the last example is really to highlight the notion that sort of COVID has really accelerated the adoption and acceptance of virtual care. So oftentimes, the technology has been in place for quite a while, but without a catalyst to really increase that uptake, folks have really not participated in that at a large scale. And with COVID and the desire to keep people safe at home, away from unnecessary emergency department visits, and really being able to have the convenience, if you will, also of being able to get that care and counseling without having to have an office visit has actually been well adopted. So one of the things that we're exploring is also to be able now to deliver not just screening to remote communities, but to deliver integrated technology that allows us to have complete, comprehensive remote eye care. And our priority population that we would like to sort of work with is First Nations. And so, whether it's by geographic access, it's clearly difficult to be able to get ongoing care. Certainly if you're diagnosed with ocular disease, that's even harder to follow up. But the notion here is that we should be able to do better for our First Nations communities than screenings, that we should be able to deliver comprehensive eye examinations, and that the technology now is available with support from the community to be able to help to access this care. And we're developing different models and exploring that technology, really to be able now to integrate how that could happen, again, to elevate the quality and the access and ability to be able to benefit from good vision health. And the part here that's quite interesting is that while we emphasize the technology aspect, the other benefit in having this collaboration with the community and support is to be able to actually to recruit folks from the community to be able to help provide an extension of that care. So an ophthalmic assistant, if you will, on site, who understands the different elements, who can provide some of that guidance, and certainly has the trust and confidence of the people in the community to be able to overcome whatever cultural barriers or access issues. And as was mentioned in the intro, I spent a lot of time down in Texas, and it reminds me of the efforts that Promotores had with the Hispanic population along the border, being able to explain and connect and be able to promote access to healthcare resources in a way that made it more accessible because of the trust and the partnership that was available. So we're very excited about being able to look at that technology. And obviously, as you accumulate and aggregate that clinical data information, it again allows us to make predictions, perhaps that could help to address and be tailored to the First Nations population. So we've talked a little bit about some 3 different kinds of project areas. One, looking at the very disparate kinds of clinical data, information, and testing, being able to aggregate all of that at scale. We have a unique position as being the only Anglophone School of Optometry in Canada. So being able to network and partner with optometrists from coast to coast, we could be able to bring together that big data to create these different data sets that allow us to develop these algorithms that could help to accelerate that development. We talked a little bit about virtual care platforms to increase patient adherence, specifically for glaucoma, but could be extended to other eye diseases as well. And last but not least, we touched upon digital health for teleoptometry and being able to deliver remote eye care to communities that might be underserved. In summary, I wanted to highlight that there are a lot of different areas across the university, whether it's in math, engineering, computer science, public health, lots of really brilliant people work, and it's a pleasure to talk, learn about their interests, and being able to see how we can make these different connections. Clearly, the School of Optometry Vision Science, with its clinical patient base, is a great partner. And I think what it does is it creates a springboard where, as we expand further into working particularly with the community, that we can partner with primary care, the hospitals, and the like regionally to really be able to leverage this sort of pilot efforts into something even more broad-based. And again, as I said at the beginning, we're tackling an enormous problem with 2.2 billion people around the world suffering from vision impairment, and we're excited to be able to make a difference and to tackle those challenges. And with that, I think I will conclude that that's an architect's rendition of a very bold initiative we have for the Waterloo Eye Institute. So we do have big plans. Thank you.
Stan, thank you, Stan. That was very interesting. Before I ask some questions, I was going to invite you. We have a fair number of participants from farther away, but there's also many local participants. Do you want to say a few words about your big initiative?
Sure. We actually have plans. They're part of a capital campaign called Seeing Beyond 2020. The goal here is to develop infrastructure that includes a clinic modernization, enabling us to deliver, again, the full spectrum of eye care services in one state-of-the-art facility. So whether it's from pediatrics all the way through geriatrics, wellness, all the way through diagnosis, management, treatment of disease, the incorporation of a surgical center to be able to help hospitals offload some of the high volume, low risk surgeries to improve access for patients and decrease wait times, and a robust biomedical science sort of renovation and expansion so that we can do a lot of the fundamental work in things like nanoparticle drug delivery mechanisms and some of the fundamental cellular type of discovery. So it's a very bold project. We're very excited about it. There's been a lot of excitement and enthusiasm from coast to coast as we've been talking with different folks. And we think that it hopefully brings a lot of different elements together, again, to support the multiple missions that we have at the university and the school. So training students, graduate students, being able to deliver patient care services to the community, and finally being able to innovate and develop very exciting research, including AI. So thank you for that opportunity.
Yes, thanks. Yeah, so that was my reaction. There is this huge opportunity for AI and technology more generally. So in other parts of the health space, I'm always shocked to see there's these incredible advancements, and then there's still people doing paper. It's so like such a broad spectrum. So can you maybe say a few words about how it is in optometry? Where are you on the technology spectrum?
Yes, so we have electronic medical records, and we're quite technologically up to date. But I think that people would be shocked that the gold standard for many in healthcare is, at least in Ontario, is still the fax. That somehow that is more secure, more efficient, more effective. But clearly it's not. And I think that again, the idea of being agent for change and recognizing that we should be able to do better in this space, that we need to overcome sort of the inertia and the siloed approach. We're fortunate to have the eHealth Center for Excellence right in our neighborhood. And they are working very diligently in coordination with Ontario Health to be able to start tackling some of these different issues. And again, the University of Waterloo as a partner with KW4 Ontario Health team really creates a unique synergy to be able to look from the frontline perspective about how we might be able to do these things better, and connect with the resources and talents and the interests of faculty and grad students to be able to really look at this maybe from a fundamental standpoint and really come up with a better system. So your question is quite pointed, because we should be doing better. We know we can do better, and we're certainly working towards that.
And could you, as a follow-up, could you speak to the data sets that are, what's the state of the data sets? I'm sure you have many, many images of, but in what form are these images, and how far are they from being usable in an AI context?
So there are a lot of different kinds of databases. So Vengu is one of our faculty, and he has a number of different ones that he's both has access and developed. And I think the challenge that we would like to sort of address is to be able to have a systematic way to gather more of those images, but with not just the images, but also the clinical data that's associated with it. I think that's the missing ingredient. So you can have libraries of tens of thousands of images, which are great, and that's what the basis of the system for diagnosing initial disease. But in order to be able to integrate the other aspects of it, we need to be able to have a systematic way of incorporating all the clinical data, the notes and the orders, the treatment, and the functional data that, again, resides in different pockets. And that is the big challenge. But because we are sort of unique in Canada and we have a strong sort of partnership with practitioners from coast to coast, the notion is that once we build this infrastructure, we can then be that repository that, again, by contributing and partnering with us in this network, we can protect the privacy of those patients and those practitioners, but we can start to be able to aggregate these data sets and start to see where those patterns lie. So we would like to actually create a new set of data that goes beyond just the images. Because that's sort of the next big space, I guess, if you will.
Yeah, it's an incredible opportunity for sure.
Mm-hmm.
Well, thanks very much, Dan. That was interesting. I enjoyed that.
Thank you.
Thank you to all of our speakers. That was a great session.